Good morning, good evening, good afternoon across the world, and a warm welcome to all the people who have joined the panel discussion on, NCDs, a life course approach to tackling NCDs. The C20 is the official engagement group of the G20 and represents the aspirations of the civil society organizations and of the common man. So we go on to this policy coherence meet, a life course approach to the prevention of non-communicable diseases. I hope the slides are visible.
Yes, ma'am.
Yeah, thank you. We're just correcting some technical glitches and we'll be back soon. We'll go ahead without a full screen. That's fine. Yeah, so a warm welcome to the life course approach to prevention of non-communicable diseases to this policy coherence meet. G20 is a group of 20 countries, a premier forum for international economic cooperation, which addresses the major issues related to global economy, such as climate change and sustainable development. And this year, India is the chair for the 2023 summit of G20. A brief background on C20. C20 is a platform for civil society organizations and non-governmental organizations, and it reflects the common concerns which affect the world's people. And it promotes the social, the previous slide. It promotes the social and economic development with the vision of leaving no one behind, making it as inclusive as possible. And Amma Sri Amata Amritandame Devi is the chair of C20 India. And so the goals of the Integrated Holistic Health Working Group, they focus on 7 areas of mental health, reduction of non-communicable diseases, elderly care, nutrition, holistic health and traditional medicine, women and children's health, One Health. And another goal is to widen the discussion on the different facets of Sustainable Development Goal 3 on good health and well-being. And just as a reminder of why this non-communicable disease needed to be a vertical by itself under the integrated holistic health, it accounts for 41 million deaths globally every year, which is 74% of all deaths. And among the NCDs, cardiovascular disease account for 44%, cancers for another 23%, chronic respiratory diseases for 10%, and diabetes for 0.05%. So we have had a series of policy events on NCDs till now. The first event was on 13th March, where we discussed a few things and also sent out questionnaires to people, to CSOs, on their opinion on what was important. And this was followed by, since there are a large number of non-communicable diseases, it was followed by another event on the 8th of April, and the third event. And today, this is the 5th event, which will focus on the life course approach and which will be in the format of a panel discussion in order to enable a more a discussive format. And there are two other events which will follow this. So this is what we'll be doing today, a life course approach to the prevention of non-communicable diseases in a panel discussion format. And we have eminent panelists whom our moderator, Dr. Thangapan sir, will introduce. And introducing Dr. K. Thangapan, who really needs no introduction to the audience. He is at present the head of the Department of Public Health at the Amrita Institute of Medical Sciences. And he was a former professor and head at the Achyuta Menon Center of Sri Chitra Institute at Trivandrum. And he was the Indian Program Director of the Millennium Promise Award of the Fogati International Center of NIH on building Asian chronic disease NCD research network for regional research capacity. He was also the principal investigator of Community Interventions for Health project supported by the Oxford Health Alliance, UK, and the Indian principal investigator of the project on building capacity for tobacco cessation in India and Indonesia, of which I was also a part and a very proud part of associating with sir. And sir was also the Indian principal investigator of the Kerala Diabetes Prevention Program, and he also figures among the top 2% of scientists across the world. With that, I will hand over the mic to Dr. Thangapan to moderate the event.
Thank you, Dr. Ashwati. So welcome back again and welcome to this live course approach to prevention of NCDs and online panel discussion. So we have 5 eminent panelists for this webinar. So let me introduce the panelists for this webinar. First of all, Timothy Evans. Tim has been at the forefront of advancing global health equity and strengthening health systems delivery for more than 20 years. At the World Health Organization, he led the Commission on Social Determinants of Health and oversaw the production of the annual World Health Report. He has been a co-founder of many partnerships, including the Global Alliance on Vaccines and Immunization, Gavi. He is the Senior Director of the Health, Nutrition and Population Global Practice at the World Bank Group. He was. From 2010 to 2013, Tim was the Dean of the James P. Grant School of Public Health at BRAC University in Dhaka, Bangladesh, and Senior Advisor to the BRAC Health Program. I was fortunate enough to visit the BRAC School when he was the Dean there. From 2003 to 2010, he was Assistant Director General at the World Health Organization, WHO. So let me introduce the next speaker. The next speaker, panelist, is the Godash Deney. He is a Bernard Lawn Associate Professor of Cardiovascular Health, Global Health and Population, Harvard T.H. Chan School of Public Health. His global health research focuses on qualifying the population level impact of risk factors and preventive interventions on cardiovascular disease globally, focusing on low and middle income countries. He serves as a core member of a global consortium that focuses on examining country level, regional, global, and trends of major cardiometabolic risk factors. He led the team that developed the first country level risk prediction model for cardiovascular diseases. Dr. Deney chairs and directs the Bernard Lawn Scholars in Cardiovascular Health Program. The third panelist is Dr. Sundararaman. Dr. T. Sundararaman was the former professor of internal medicine at Jawaharlal Institute of Postgraduate Medical Education and Research, JIPMER, in Pondicherry. Former professor and dean in the School of Medicine and School of Health System Studies at Tata Institute of Social Sciences, Mumbai. First director of State Health Resource Center, SHSRC, Chhattisgarh, from 2002 to 2007. And he was the executive director of National Health System Resource Center at Delhi, and also founder member of the All India People Science Network and Jan Swasthya Abhiyan. Our fourth panelist is Asmita Mehta. Professor, she is a clinical professor and HOD of Pulmonology, Amrita Institute of Medical Sciences, and also nodal officer of the National TB Elimination Program She was the National TB Elimination Program in Ernakulam district from 2012 to 2015. So now our fifth speaker is Dr. Vijay Kumar. So Dr. Vijay Kumar is the former HOD Health Head of the Department and Professor of Community Medicine, Government Medical College, Thiruvananthapuram, and also at Amartha Institute of Medical Sciences, Kochi. He is the Honorary Secretary of Health Action by People, and he was doing a pioneer work with communities. He has spearheaded the Ardram project of the government of Kerala. So these are our eminent speakers. I think I have a few questions to all of the panelists. Let me start with. Let me start with Dr. Tim Evans. My first question is to Tim Evans. I hope he has joined.
Yes, I'm on the line.
Okay.
I'm not on video. But
Thank you, Tim.
Okay. I hear you loud and clear, and I am on the line.
Okay, thank you. So the first question is, non-communicable diseases push people into poverty, all of us know. Is universal healthcare the only magic wand? Your blogs mentioned that Africa can end poverty. What lessons can all countries, particularly low and middle income countries, learn from that? So that is my first question to Tim.
Great. Well, thank you very much for the question, and thank you very much for including me on this panel. And my apologies in advance because I do have a commitment in about 15 minutes that I have to run off to. But I think what's very important in understanding or thinking about the concept of universal health coverage is really that it has three critical dimensions. One is a view of trying to make sure the entire population, especially those with greatest needs, have access to life-saving or health-enhancing interventions across the life course. The second is that those interventions that one might want to have access to will change over time and need to consistently be triaged in terms of which ones will do the most good for the most people. And then the third axis, which is really critical, is the way in which healthcare services are financed. And this really suggests that all of the evidence on healthcare financing suggests that systems where there is prepayment and some form of subsidiarity associated with insurance are ones that, one, promote more access, take away financial barriers, and two, allow the system to organize resources in more efficient ways than systems that do not have any prepayment arrangements. Now, the challenge in many low and middle income countries is that many of the reforms that characterize prepayment in OECD countries related to large government financed programs and or social health insurance are ones that are not necessarily the singular solution in many low and middle income countries. And there are two dimensions of that that are absolutely fundamental to be clear about. The first is the nature of the economies are very informal. And because those economies are informal, the vast majority of people working do not get a regular paycheck. And when you have informal means of payment as the primary mode of employment in economies, then it's very hard for social health insurance systems whereby employers make contributions to engage. So the Bismarckian system, the one that was pioneered in Germany in the late 1800s and taken up in many countries of Europe and the United States, a social health insurance system, is not one that goes well with the nature of the economies in many low and middle income settings. But on the other side, if you look at the tax-based systems, which are closer to the UK National Health Service or Canada's system with provincial health insurance, those rely on very strong taxation systems. And taxation systems need to be generated through public treasuries. And if we look over time, that the rate of growth of taxation in many low and middle income countries is probably not sufficient to facilitate a full financing of universal health coverage through a public financing system. It doesn't mean that that's not very important to push. It's just that it won't be the singular solution. So in that setting, if social health insurance isn't the panacea, nor is the single national tax-based system, then we're looking at a mixed financing system. And that's where I think low and middle income countries, through investing in innovative financing mechanisms, really have an opportunity to create 21st century paths towards universal health coverage that will be truly innovative and independent and owned entirely by those countries. So Professor Takapan, I'll stop there because I feel like I've probably gone on long enough on your first question.
Thank you very much, Professor Tim. I think that was an excellent comment on insurance and also other financing mechanisms for NCD. And all of the countries, I think people are pushed below poverty line because of the catastrophic health expenditure. Let me go to the next panelist, Dr. Vijay Kumar. Dr. Vijay Kumar has worked extensively in the decentralized government system in Kerala. So my question is, what are the key lessons for countries across the world? Is decentralization the key for all countries? Over to Dr. Vijay Kumar.
Hello.
We can hear you. Go ahead.
Thank you. Thank you, Dr. Thangapan, Dr. Ashwini, and all those who have organized for giving me an opportunity to be here with the esteemed and great personality around. And coming to the question that you have raised, the question itself, just one cannot say that this is the solution for all the ills that we suffer. But at the same time, the key lessons that the countries across the world, my knowledge around the world is very limited. I know a little bit of Kerala and maybe India. There's a time limit is there, therefore I'll just rush through the points only. So wherever decentralization is being implemented, it should be tailored to the local needs and conditions, and doesn't actually, not one size fits all approach will not succeed. The next important point is it requires a strong legal framework. Wherever we are going to implement it, we require a strong legal framework. And requires effective communication with the different stakeholders. We need adequate financial resources to manage it. And local elections and citizen participation can enhance the accountability and transparency. The decentralization effort should be accompanied by measures to promote transparency, accountability, and anti-corruption, and collaboration and partnership with the public, private sector, civil society organizations, monitoring, and it requires a strong political. These are all the lessons that we actually learn through the process. And if you ask me about the alternatives are traditional. It could be a centralized one, or it could be a federal or confederal or even unitary type of governance. There are hybrid governance as well. hybrid governance means it could be at the different levels, different sectors, restricting certain development sectors to certain local or maybe central area like that. These are all the general lessons. And coming to is it the key for all? Then it's a difficult question. It could be an effective approach for improving governance in many countries, but it is not one size fits all solution. In some cases, decentralization may exacerbate existing inequality or lead to fragmentation and instability. It is important to carefully consider the local context, including the distribution of resources and power before implementing decentralization policies. Additionally, successful decentralization requires strong institutions and capable local leaders who are able to effectively manage and coordinate decentralization. These are all the answer that comes to me the first hand. If requires further discussion, we can actually discuss it further. But overall, it requires careful planning, maybe strong legal institutional framework, active participation of the stakeholders. When implemented effectively, it should lead to more effective and efficient public service delivery. This is a nutshell what I can actually tell.
Thank you, Dr. Vijaykumar. We will come back to you with another question later on. Maybe let me go to Dr. Sundaraman. Dr. Sundaraman, the role of health system across the world is to take care of all illnesses, including chronic illnesses. Have health systems across the countries changed from acute care to chronic care? What needs to change fundamentally? Over to Dr. Sundaraman.
Great diversities in health systems. The architecture of health systems that tends to do best with chronic illness are a network of comprehensive primary healthcare providers who are able to provide continuity of care at the horizontal level as a chronic condition, provide a health plan over years and years, a continuity, plus provide the necessary referral services. So continuity with vertical referrals also is an important issue. Now, something like the National Health Services of UK or the Highlands system is able to provide this. But for the most part, especially in the private sector, even if you have a chronic illness, you visit each episode of diabetes visit, each visit to the clinic is in effect a separate visit, financed separately on a fee-for-service base, and therefore optimized in that particular relation. The availability of health plans where an individual can buy instead of an episodic health service, a health plan is available in some of the developed countries as part of insurance schemes, voluntary insurance schemes, but generally not present in LMICs altogether. And public systems do poorly in most LMICs in providing this level of continuity of care. Not that we don't know how to. Tuberculosis and HIV are two chronic illnesses where we do very well, relatively, in terms of providing a continuity of care, managing a chronic illness. But the state is able to give it priority because these two diseases have a very high externality and you're worried about them spreading. Whereas in non-chronic illnesses, since there is no externality, they become much more low in the priority. And you had this whole 25 years of this selective healthcare approach, which willy-nilly excluded all chronic illness care from all chronic non-communicable disease care from the healthcare system across most LMICs. And we are really having great difficulty in crawling back. So I think it is a huge transition because we need to think from selective healthcare to moving into how you're able to give a comprehensive set of healthcare is very important. And you just can't use cost-effective analysis to fragment the package of care you're giving. If you have to treat diabetes, you have to treat diabetes fully, including managing complications, preventing complications, primary care. A whole lot of areas get involved in this. So I think that transition of healthcare to managing is related very much to the selective to comprehensive transition also. we have a long way to go in most countries.
Thank you, Dr. Sundaraman. I think I will go to the next panelist, Godas Denai. So my question to Professor Denai is that what is the role of risk factors on health disparities within or across countries, in particularly related to NCDs? What are the impact of population level preventive interventions on health disparities? Over to
Thank you.
Professor Denai.
Thank you. Thank you for inviting me to this panel. I would start by saying they have a substantial role on disparities across countries. We know that, for example, for cardiovascular disease, which was mentioned in the beginning, large proportion of NCDs, we have had trends in the past decades where a lot of high-income countries and now some upper middle-income countries have had substantial reductions in the rates of cardiovascular disease, up to 50–70%, whereas in many lower middle income countries and low income countries, those trends are either flat or sometimes even increasing. And the major risk factors, of course, as we know from experiences and projects like the Global Burden of Disease, for example, are unhealthy diet, smoking, high blood pressure, and the like. So these contribute a lot to disparities across populations, and in some research papers and quantifications, up to 50% of these differences can be attributed to these risk factors. But even within populations, we know there are massive differences. If you take, for example, education as your dimension or income or something like that, you will see disparities. And what we see also is that these trends and disparities across socioeconomic status flip over, whereby in the past we were talking about NCDs being diseases of affluence. So more high-income people, more educated people were grappling with things like obesity, diabetes, hypertension, whereas in many of middle-income countries and now increasingly in low-income countries, this is being flipped. So we have the double burden of poverty and diabetes, hypertension. Many people are eating the dense, calorie, unhealthy diet because now they can afford it. And that leads to either a flattening or reversal of these, again, double burden of poverty and obesity and diabetes among the poor in many of the countries. So that has been quite challenging because, as was mentioned by our previous panelists, the health system doesn't typically deal with these conditions, and more so doesn't deal with them well among the poor population, leading to substantial catastrophic health expenditures, for example, among the poor. This shouldn't be the case because, again, as was mentioned before, we do know a lot about how to control, for example, hypertension and how to deal with smoking, for example, at least at the policy level. WHO has a very strong set of recommendations for both the Empower package, the HEARTS package. A number of countries have been trying to do those things at the smaller level, but sort of the momentum is still not enough to reverse the tide there. Are population level interventions successful in reducing disparities? It depends, I would say. It depends on where the disparities are coming from and what the interventions are. For example, there is good evidence that taxation on tobacco is progressive and leads to more impact on tobacco smoking among the poor, and therefore that might be a progressive policy and reduce the disparities in cardiovascular disease. But if our intervention, population level intervention, for example, is based on access to care, it may not necessarily reduce disparities. So I think the answer will depend. And here, I guess I would like to put a plug on capacity building. To answer that question for each country, we need to do national, regional level studies on NCDs to understand the risk factors, to understand the distribution of risk factors in the population, and to understand whether what combination, I guess it's always a combination of population level versus group level or individual level interventions is optimal to reduce health disparities. I'll stop here. Thank you.
Thank you. Thank you very much. I think we'll come back to you with another question maybe after the first round. Our next panelist is Dr. Asmita Mehta. So my first question to Professor Asmita Mehta is that the COPD, chronic obstructive pulmonary disease, is an emerging public health problem across the world. What measures would be the most effective in controlling the condition at the population level? Dr. Mehta, please.
Thank you so much for the invite. Am I audible?
You are audible, very much.
Yeah. Thank you. Thank you. Thank you so much for the invite. And the question is, how can we
Can you
decrease
adjust
the
your
burden
camera,
of,
please?
burden
Yeah,
of
now it's okay.
COPD
Little more.
now in our population? Yeah. Okay. So, as we are aware, the latest WHO data says that the COPD incidence or COPD is the 23 million deaths in the year of 2019. So you can understand what is the severity or what is the gravity of situation, and why all other non-communicable diseases, the burden is coming down, the COPD burden is increasing. So it is the need of time that we do something about it. And how can we control the COPD at population level, which will require a multifaceted approach. So, and in any kind of population control diseases, we have to concentrate not only on the diagnosis and management, but we have to concentrate on prevention also. So first and foremost, the prevention of COPD will be very important. So we should encourage people to avoid smoking, as my previous panelist told, that we can make a stringent laws for tobacco smoking, as well as put more taxes on tobacco, which will indirectly may affect the smoking habit of the people, which we can decrease, which will indirectly decrease the COPD numbers. The second foremost cause of COPD is air pollution. So if you will decrease the exposure to air pollution and encourage people to avoid air irritant, then also the COPD can be prevented. The second most important thing is early diagnosis. Most of the times we diagnose COPD at the age of 70, while the COPD starts at age of 40. So promoting early diagnosis, for that we have artificial intelligence. Like recently we come across the Swasa device, in which we can do screening tests at the population level. So if we will promote early diagnosis and screening, that also will indirectly help us to control the COPD among population. The third most important is, if the people have already developed COPD, to decrease the mortality, the treatment should be easily accessible. So for improving access to effective treatment options, the treatment options also include pharmacotherapy, rehabilitation, which can be made available, and sometimes even surgery can be made available at the community level. The disease management programs, which includes not only public but the private partnerships. So there should be, just like in TB, what we are doing is public-private partnership. The same way we can start some program, and I think at some level the SPASTA has started doing those kind of programs, in which the community people have referred the difficult cases to the private, and vice versa. From the private, people have referred to public sector thing for the collaboration of medicines, as well as the other extension of the treatment. Health education comes very important when you want to control or spread awareness about some programs. So we have to sensitize people the harmful effects of inborn air pollution and the side effects of air pollution. All those things can be, if we will make it properly aware, people will be aware of that, then they will try to decrease those exposure, which will decrease the indirectly incidence of COPD. So there should be a policies to regulate air pollution, just like recently, I think when the pollution level was very high post Diwali in Delhi, government decided odd even number of vehicles. So there should be some policies to control outdoor as well as indoor pollution. So it depends, and it needs a visionary politician for doing that. And I think overall, these measures, I believe, can help to reduce the incidence of COPD by prevention, early diagnosis, as well as the policies to develop the control of pollution, which will lead to better population health. That's what I believe. Thank you so much for that question, sir.
Thank you very much, Professor Mehta. So we will have another round of panel discussion. I think the second question. Then after that, I think the participants will be able to ask questions either through the chat box or they can ask directly the questions to the panelist. I hope the Tim Evans has left because he said he will be available only for the first half an hour. So let me ask Dr. Vijay Kumar again. It is understood that you are working with the elderly through the local self-governments. Is this experiment scalable? Is development of decentralization the answer? What alternatives should other countries think of? Dr. Vijay Kumar, please.
Well, it's not a single question, rather there are three, maybe even four dimensions to the questions.
Yeah, I can repeat the question.
Yes, coming to no, I got actually I have received your questions well in advance. Therefore, I have actually prepared something to respond to you. And thank you. That's actually, this is much more close to my heart. It's not exactly close to my heart. Rather, at this age, I do not have much work to do. Therefore, I thought I will just start working with the elderly population and quality of the elderly population in Kerala. Basically, because I don't have any other job to do. And I enjoy it also. And coming to the first question, is it a scalable? That is something which everybody has to think of. It need not be the scalable one, and it could be scalable one also, as we were discussing in the first part of the question about the decentralization and local governments. So, considering the social, cultural, and maybe economic leadership and the governance style, naturally, this can be adopted. It can be adapted to different social settings across the world. That part is clear in that context. And coming to the question of is it the right answer? Definitely, there are two aspects of there: centralized or decentralized dimensions. Both these has got its own relevance in addressing the issues of the elderly subjects. Say, for example, developing and implementing policies that prioritize the needs and well-being of older adults. This could be actually developed based on the experience of the working with the local or decentralized approach. Similarly, providing resources also. Resources in terms of money or even the skill or maybe even the concern, human concern. Naturally, it comes from the community-based program and serves that support the elderly. It actually encourages and supporting community engagement and participation in programs that promote healthy aging and social connections. Promoting intergenerational programs. That is actually something which we have to look forward to for whenever we want to actually address the issue of elderly subject. Basically, because unlike in the developed countries, for us, the proportion of elderly has increased to maybe 18 or 20% or even 22% in some of the districts within one lifespan. While many of the developed countries actually reached that sort of a proportion over maybe 50 years or 100 years. So our society needs to learn itself the process by which it will be able to take care of its own elderly subjects. Then intergenerational programs are actually key to that. Creating and enforcing standards for healthcare facilities. Even disability or even elderly subjects, the way in which they seek care, the health system and the way how the health system interacts with the elderly subjects. These are all actually something which can be promoted the local or maybe decentralized approach. Then setting the standards, maybe implementing this the transport systems, supporting the housing option, barrier-free environment, providing resources for caregivers. Actually, when we speak about the health of the elderly subjects, it's not only the health of the elderly subjects, the people who are actually taking care of the elderly. In our setting now, actually even 3, 4, or even sometimes even 5 generations are living together. It adds, say, what do you say that a 65 or 70-year-old person taking care of his father or mother who is in their 90s? You know, the burden of the caregiver, who themselves are actually the elderly subjects, is something which we have to actually consider, and it can be addressed only with the decentralized approach. Education programs are needed, especially for actually bringing in this intergenerational programs, and naturally monitoring and supervision is the best in the decentralized system. But at the same time, what we should understand is we require certain centralized programs, centralized policies, bringing in public and private partnerships, bringing in maybe non-profit organizations and community-based groups that provide direct services, international organization and institute, because if you look at the knowledge that we have generated, the knowledge related to the elderly subjects are very, very, very minimal. I was actually astonished to find that, say, when you speak about the NCD, for example, it was a question that actually have asked something back. When it comes to the 80s and 90s, do we actually, what are the standards? What are the cutoff that you're taking? What are the preferred drugs? Is there, will you suggest? So these are all, so many areas are actually unaddressed and unexplored. We need to generate that sort of a knowledge to, so all these things could be done at a different level, not at the decentralized level. Then coming to the social and cultural norms, you know, better to have at the decentralized level, but at the same time, you know, it can be prioritized and respect the elderly and promote intergenerational relationship. This could be done at the local level or maybe at the central level itself. And you know, promoting family-based care support system, family-based and care support system, and at the same time building certain institutions which will actually take care of the subjects or people who are unmanageable at the domestic level. So we need to have certain centralized programs for that sort of thing. Similarly, requires that technological innovations are needed to address these issues of the elderly, and the whole society needs to be educated. It requires a lot of collaborative efforts between central, state, local government, academic institutions, research. But by and large, this is actually neglected. This is what I feel about the elderly, the life of the elderly in Kerala with the limited experience. So the alternative, what alternative should other countries think of, means actually there are no alternatives. Whatever way by which we will be able to address, whether it is local or centralized, we need to actually combine all these things together. Then only, because the problem is increasing everywhere around the world now. What we see is the proportion of elderly is increasing. Actually, when I was discussing with something at some of the panchayats, the one solution which they have suggested is, okay, let us discuss. Let us actually put the cutoff at 70 years, so that the magnitude of the problem is limited. So that, say, for example, from 22 straight away it comes to around 7% or 8%, or maybe less than 10%. The world over, these sorts of experiments are happening, setting the cutoff at the different age levels, but at the same time, the problem stays at each and every other societies, whether developed or developing countries. We need to actually build and develop different strategies and approaches to address it. Let's stop with that unless there is any question.
Thank you. Thank you, Dr. Vijay Kumar. We will come back with the questions from the audience also. Let me go to Dr. Sundaraman with my second question. As a lifelong activist of people science movement and people health movement, what is your opinion? What, in your opinion, needs to be an essential part of policy for the prevention and control of NCDs? How important or inclusive is a life course approach, which will consider the needs of all age groups and addresses NCD prevention and control in its earliest stages? Dr. Sundaram.
That's a question to me. Are you able to listen?
Yes, now okay.
So So very few questions ask me this question, and yet a lot of my effort goes into this. At the level of policy, I think one of the great roles that the people's health movements and science movements have done has been a sort of unrelenting champion of the health for all concept from the Alma Ata days, including its adoption in the Alma Ata had a big role. Now, Zafarullah Chowdhury, one of our great stalwarts, recently passed away last month. So even from the adoption of the declaration to championing its declaration through the dark times of neoliberal policies, we have had a major role in championing, and that at the centrality of that is a comprehensive primary healthcare network. That's one important policy requirement. I already mentioned this in my earlier for the first question. But the second point, which is also a matter that people's movements have taken up, is much more serious action at the structural determinants of health. It is at the social and the commercial determinants of ill health. It is not a matter of individual behaviors alone. Whether we know that from tobacco and alcohol, it is also how the industry promotes, how the industrial policies are constructed, how state policy is constructed. But what we know in tobacco and alcohol, we need to apply to areas like sugary foods, commercial foods, all the ultra processed foods of low nutrients and high saturated fats. These are not things that have happened by nature. These are things or happened because poor people don't know to behave. But these are behaviors that are imposed in different settings. But going even beyond, when you look at, say, COPD, for example, you also need to take into factor extractive industries, the whole of the occupational health scenario, the huge burden of disease related to lung disease that comes from silicosis, from high dust levels, from air pollution. So at some point, you're talking of major determinants, so it's not something that you can manage without major changes in different intersectoral interventions. And finally, and not the least, in this whole discussion of NCDs, we tend to, I once compared across the developed and developing countries. You still can't account for the very high burden of diseases, of non-communicable diseases, even before the so-called epidemiological transition. That's a little bit of a myth. It's just that this has become a greater proportion of deaths because deaths due to communicable diseases came down. But if you look at age standardized death rates due to major non-communicable diseases, they have been always very high in developing world. And one of the reasons which we, going beyond your conventional things, are factors related to unemployment and the huge financial burden and its implications related to stress in a very unorganized work environment where something like 90% of the workforce are unorganized workers with no social security, no job security, extremely deplorable conditions of work, and constantly under debt and managing to cope at the bare margins of existence. So you cannot reduce non-communicable diseases to something that doctors and health systems need to do about. And therefore, to find this balance, that doesn't mean that you do not have a right to healthcare for chronic illness that needs to be deployed in a community-based and people-friendly manner. That is one right which is inalienable. But you cannot also have that in the absence if you are looking at costs when you continue to generate more and more non-communicable diseases through the commercial determinants of ill health. It's good that WHO has finally recognized and taken some action on the commercial determinants of ill health. It's a long way to go if we are going to really get a cap on this problem. Thank you.
Thank you. Thank you, Dr. Sundar. We will come back to you later. I think, let me go to Professor Denai with the second question. Is a common risk reduction approach the need of the hour? If so, which of these risk factors, such as tobacco, alcohol, physical inactivity, unhealthy diet, etc., among these, which of these risk factors will be the easier to tackle? Professor Denai.
Thank you. It's still a difficult question. The most successful cardiovascular disease prevention program at the population level that we know of is the North Karelia project. Back in the 70s, Finland, state of North Karelia, had the highest rate of cardiovascular disease, something in the order of 600, 700 per 100,000 people. And through a multi-pronged, multi-level, population-level prevention program, through several decades, they reduced it substantially. They still are in the middle of the range of rates, but that program controlled hypertension, changed people's diet, reduced smoking, a lot of awareness, a lot of population level interventions, but also health system level interventions. And that has been widely studied and publicized. And for the past few decades, my dream has been to have a modern North Karelia program. And for a while we were talking about Kerala with Dr. Ashwati and others. Can Kerala be the mother of, because we are starting from high rates in Kerala among all Indian states, can be that the next example? But of course, what it took in Finland was a group of scientists who were very involved and generating the evidence for this intervention, a group of politicians who were involved, and Pekka Puska was the lead of the program, eventually become a member of parliament. So there was a large number of, I guess, stars aligned quite well for North Karelia in order for that to happen. Where else in the world can we replicate that experience? I don't know. But what can we do easy, following what was mentioned by Dr. Sundaram? If we have that nice, functioning, high quality primary healthcare network that works well both horizontally and vertically. Not many countries unfortunately have that, but something like hypertension control, we should think of as a low-hanging fruit. It should be, but it isn't. A lot of countries are pushing for it, but we are still following the same story of a half are diagnosed, a half of the diagnosed are treated, a half of the treated are controlled. So the cascade is not working well at all in most countries. But we have examples we can pick up on. Iran recently has been doing well. Turkey has been doing well. And there is no magic formula, really. It's the same basic Alma-Ata declaration. If people have their doctor, maybe 15 per 100 per one or thereabout, and they know where to find them, and the doctors know how to treat or scale up. And now we are talking about task shifting and maybe letting the nurses follow up or the community health workers follow up. That's great. We had a successful study in Kerala where one of our scholars used the Kudumbashri unit, the women self-help groups, to scale up hypertension control, and that worked very well. So we are looking forward to expand those types of interventions. And I also fully agree that on other fronts, the diet has been quite difficult because of these commercial interests in, unfortunately, unhealthy diet. In principle, the people should eat a healthier diet, therefore the companies should follow suit and provide healthier diets, and some of that is happening in some high-income countries, but not, unfortunately, in low and middle-income countries. Therefore, although folks, international organizations, nonprofit global organizations have been pushing for example, a ban on trans fat, some countries are doing better. Again, other countries are still a large proportion of fat in the diet is trans fat. Similarly, the role of high salt diet on hypertension, stroke, and the entire cascade of NCDs, we know it's important. We have been trying to get it down. Not many countries have been successful because it requires both regulations and possibly taxation, but not so much. But basically pushing the industry to reformulate their packaged products and also educating the population. So it runs the gamut, and we have to be using both our health system approaches and financing them better, as Dr. Evans was mentioning. We think of these as basic human rights, but many countries can't afford that same network of primary healthcare centers because they are not investing enough in their health systems. Once that's in place, we can do hypertension control, our diabetes management. After that, maybe better, and COPD and other NCDs. But we have to then widen up to these social and structural determinants of health. Thank you.
Thank you, Professor Danai. And although you were saying hypertension control is a long-hanging fruit, no, even in a state like Kerala, which is the most advanced in epidemiological transition, health systems, education, etc., the hypertension control rate is only 12.3%. So it may not be a long-hanging fruit in many places. That's one issue. But maybe now I would like to ask a subsidiary question among the diet issue. Now, the Framework Convention on Tobacco Control is a success story, I think, many places. Can we have a similar convention for diet control? A small question.
I don't think so. Unfortunately, we recently had one of our visiting professors talking about what's happening with the pandemic treaty. This is years in the making now, several years, of course, not more, where negotiators from all governments are trying to come up with an international agreement on what to do in case of the next pandemic. And my understanding and knowledge based on that discussion seem to tell me that not all of our goals are amenable to an international treaty or regulation. I suppose if you push something like, I don't know, healthy diet in the context of, let's say, omega-3s, healthy fat from seafood, countries who are landlocked and don't have enough of that, they will identify that as push lever from the international community. We don't have fish. What are you talking about? Or countries who are producing it will be on the plus side. My understanding with limited knowledge of international law is that it's very complex and complicated to come up with an international agreement where some countries are producing something, some countries are consuming it, and it cannot become sort of a panacea or a magic bullet to say, okay, everybody should get 5 servings of fruit. Yes, but what fruit? Is the fruit it should be mangoes or it should be watermelons? And then India and Spain will be competing for that number of I don't think they necessarily are. Maybe for alcohol we can do something like that. But for the rest of the elements of the diet, they are very much embedded in the local cultures. I think a lot of it has to do with sometimes, and most times I would dare say, going back to what we were eating a little bit before the foods were commercialized and industrialized. And if you ask, I think, like the Vijay Kumar or anybody else who has done community work, and I've done it in my country, Iran, you go back to people before white bread, what did you eat? Of course, there was some type of whole wheat bread because you were just grinding wheat and eating it. But then white wheat came from some country, industrialized country, and people liked it and they started consuming it. And that led to potentially some of the increase in diabetes.
Thank you. Thank you. Let me go to Dr. Asmita Mehta again with the second question. What proportion of COPD may be contributed by air pollution, particularly indoor air pollution? How much does indoor air pollution contribute to COPD? Dr. Mehta, please.
Thank you, sir, for that question. So as I said in my previous answer, that COPD is the 3rd leading cause of death. Not only that, if you are talking about the quality of life and all, COPD is the 7th leading cause of poor health worldwide, measured by the disability adjusted life years or DALY. Now, coming to the question that is about the indoor air pollution. So nearly 90% of the COPD deaths in those under 70 years, when I was telling that the diagnosis of COPD in country like us happens around 70 years of age, but the deaths of those particular people who are dying below age of 70 also are maximum in the low to middle income countries, particularly. Tobacco smoking accounts for over 70% of the COPD cases in high income countries. And in low middle income countries, tobacco smoking accounts for 30 to 40% of COPD cases. So if there was the one trial which was published by Dr. Sandeep Salvi in the Journal of Respirology, in which he did a study in India, in which he found that the 47% of COPD which was happening in the female was actually due to the indoor air pollution. So it is almost equal to 50% of the cases of COPD in the developing countries are due to indoor air pollution. So according to WHO, 3.8 million deaths which happens, the most of them is caused by COPD, and 50% of that is almost due to indoor air pollution. However, the exact number nobody knows, and we can't argue because there might be definitely some overlap. So what is the reason for indoor air pollution? That because in the developing countries where many households still rely on solid fuels like wood or charcoal or coal for cooking and heating, so indoor air pollution contributes significantly to COPD, particularly in the northern parts of India also. And in this particular region, the indoor air pollution is estimated to cause even up to 50% of COPD cases. On the other hand, in developed countries, outdoor air pollution and smoking are the primary contributions. So basically, as I told that most of the times it is the low and middle income countries or the developing world in which the indoor air pollution amounts around the 50% of the cases. So proper ventilation and use of cleaner energy resources can help to reduce indoor air pollution and prevent COPD and other respiratory diseases. That will be my take-home message for you. Thank you so much, sir.
Thank you. Thank you. I think now this is open to all the audience. You can ask questions, comments, etc. Please. You can also put your questions in the chat box. Yeah, there is one question in the chat box. My question is to Dr. Vijay Kumar, sir. Sir, you mentioned about hybrid government. Can you explain some more about that? Dr. Vijay Kumar?
Okay, it's actually, thank you for actually raising a question. I'm not an expert in the governance, but at the same time, I little bit, I know my knowledge is limited. Hybrid governance is actually a mix of different systems. It could be central, state, local, or non-state entities. You know, each has got its own advantages and disadvantages depending on the size, political history, and cultural and social values. What we have to understand is that, you know, say for example, certain development sectors, it is centralized. Certain development sectors, totally decentralized. Among this development sector itself, certain, say, research, centralized. These sorts of mixes. Now, when you say decentralized totally, it could be totally decentralized. Here, what we say is there will be certain parts are centralized, certain parts are decentralized. That's what we call as the hybrid governance. I hope it is clear, or I can take more time. Then I have to speak about the whole governance system. That's a practical problem. Hello?
Yeah. Okay.
Is it okay?
Yeah, please go ahead. Yeah, please go ahead, Vijay Kumar.
But what, sir?
Yeah, you can go ahead. You can continue, please.
So what we actually, what I would love to continue is with the elderly issue itself, because we were actually a question which actually I have not elaborated much in the first time was because of the lack of time. And there was a question from Dr. Tangappan that it is, what are the alternative to decentralized governance? So what I suggested is that, you know, it's actually something similar to the hybrid governance that we have. See, when we speak about the decentralized governance, when we speak about the life of the elderly, what we will find is that we can actually, the role of the national and international agencies, academic systems, or maybe developing strategies and policies, these are all one area where they can come together. Then we can actually think of maybe setting up the national, maybe elderly state level or at the central level. Then it comes to implementation level, most of it, practically taking care is done by the family. And maybe the community can support the family to take care of the elderly. So basically taking them away from the institution. But at the same time, institutions are also necessary for certain conditions. This is a typical example of the hybrid governance system. International, national, state, and local, and maybe at the family level, individual level itself. Each has got its own relevance and importance in providing and building the care systems. That's what I would love to add to the hybrid
Thank you.
governance.
There is a question from Dr. Shibin Shaji to Dr. Sundararaman. How can we improve the continuity of care for the NCDs, effective as the care given in TB, etc.?
Good question. This is something that we are today facing as a challenge in India. Currently, we find this as one of the great weaknesses. The common answer in today's climate is digitization. And there is a trend to give that answer too prematurely. I think digitization will add value, but digitization is not the heart of the problem. Digitization only facilitates if the systemic connects, the institutional connects are good. So what would I emphasize? I would emphasize first that there is a team approach. That, you have to ensure that there is a team that follows up, and whether the person who is handling the referral feels part of the primary care team that he is supporting. But also at the local level, there is a team, the person who visits the house, there's a person and the nurse who follows up in the center, the doctor over there, they work together on that. And if it is just between the doctor and the patient, it's not possible to build up. And most places, it is the nurse, the care managers. There is a particular entity that somebody acts as a care manager that looks at it. It's important. I would also emphasize the very commitment, the very fact that you say that, for example, in most of these effective primary care countries, there is an incentive given to a team if they have screened everyone, identified people, and they manage to keep them in their blood pressure control. So if they get over 90% of the persons who are hypertensive and diabetic and on treatment, if at the end of the year their control has been good, they qualify for getting a performance incentive. This is there in the UK, it's there in Thailand, it's there I think, which is difficult. You can opt out some people. You can say, okay, I will get out of my 105 patients, I will guarantee it for 104, but please don't include this guy. He's not going to listen to me. I mean, you can exclude that, but having set your target, you can actually go ahead and do that. And then it's not about the incentive. The incentive won't make the difference, but the incentive provides a value, provides a recognition of the importance of actually providing that continuity of care. So therefore, the combination of a team and an importance of the recognition of the importance of a thing is the fact that makes the big difference, and digitization will help because then you are able to follow up on that. So in that order, I think it's a good idea on that. I see this team concept as an important concept. We have a lot of discussion on the team. That's the next question I'm seeing from Shalini. So I'm just going ahead with that. There's a lot of interesting discussion now on what is the primary care team. Is a doctor necessary? Mid-level care providers? How many nurses do you need? For a population of 5,000, how do you need? A team will cater to what population in a rural area, in an urban area? So I don't want to actually foreclose that discussion. The team, which is the appropriate team in a population, will have to emerge based upon both human resource availability and the commitment of the government to invest. At this point of time, it is enough to recognize that a multi-level team, that it is not just doctors, it is doctors, nurses, community health workers who are necessarily part of this team. if you accept that commitment, then we can actually look at the details depending upon each context. But again, what it means is, what is the end of the day? End of the day, it means that this life course approach that you are talking of, you are actually able to implement it for a population at a population level, meaning that you know that these 5 people have all been covered. Even those who did not come to the hospital or to the health center, have outreach has met them and ensured that they have been brought in. So the team must be good enough to do that. And that's, I think, the greater definition than to say how many nurses, how many paramedics. I can say that, but there are so many successful examples with different combinations across the world that I do. And also remember, everybody need not be within that primary health center. Some persons, for example, in mental health can be shared between 5 centers. The ophthalmologist can be shared between, sometimes in India, it's large districts, but between a number of blocks. So you don't, that the notion of a team has to be constructed within a context, but you need a team.
Yeah, just to ask Dr. Danai, now you have mentioned about task shifting, etc., for the hypertension control, etc. But can you add something to, you do have a comment on this team approach, which the question has been raised about the team approach?
Yes, of course. Absolutely. No, I agree completely. And task shifting can only, I suppose, happen within the team, because unless the team is there, there would be a hodgepodge and mix, and things will fall through the cracks, and the cascade may be even more broken. Some countries and provinces have been experimenting with task shifting typically from doctors to lower levels, including a nurse. Other countries, I know our colleagues in Chile, for example, have been dealing with a large part of their health budget, as in many other countries, is going to people with multi-morbidities, several NCDs at the same time. This can be, as we call it, sort of concordant or discordant, either all in one group of cardiovascular disease, the person has diabetes, a stroke, etc., or they have hypertension and depression across mental health, or COPD and cardiovascular disease. And they several countries have found that a coordinating person, a coordinating nurse, or a coordinating agent, which sort of ties in the various elements, works well. I completely agree with Dr. Sonaram that higher sort of cost healthcare personnel, like a specialist, can be shared. There is a famous example in Cuba back in the day where they had like a visiting cardiologist comes to your center every week, or you can share a cardiologist across the district or province even. And some of our colleagues in other countries are also experimenting with that model because typically those are not as urgent conditions. Some issues come up with legal, for example, and compensation issues. If the doctor is not providing the prescription and the nurse is, who is getting the compensation for it? So some of those things are sticky issues that at the higher level, they need to be discussed first.
So we have a subsequent question to that one.
Shall I add?
Yeah, please go ahead.
See, when discussing about the team or even task shifting, I have got an experience to share with you. Say in Mararikulam, Kerala, Alappuzha district, the number of hypertensives detected were on more than 90%. And of all the people detected, 95% of them take medicine regularly. It was the status 6 months back, 6 months or 1 year back. Now I do not know. There were not different teams working, rather it is the existing PHC system with Asha, Anganwadi, and maybe local volunteers. I'm not saying that the hypertension was controlled, but what I'm saying is whatever medicine was available at the public facilities were actually reaching and they were consumed. The difference was brought in by the local leadership, decentralized approach. So it is also possible I do not know whether such models are existing in different other parts of the India, but here it was working till some time back. Primary prevention, of course, you can think of it is not actually as improved as we have to have, but at the same time, identification or maybe screening, diagnosis, and administration of drugs to more than 90% is working. I stop.
Yeah, there is a question from Mr. Durga Das Savant. Can you speak? Can you raise the question?
Yeah, thank you.
Yeah.
Its theme is integrated health, and medical science is just one approach. Unfortunately, we are discussing much from the medical perspective only. Unfortunately, in medical science, mind is, I think, most neglected aspect. And mind is very important. Mind is responsible for disease, and mind is responsible for cure also. And in this entire discussion, we are hardly discussing about the integrated approach of health. It is not only the medicines and the medical science approach. We should discuss about the integrated lifestyle, what we talk about, total, ahar, vihar, nidra, what Ayurveda talks about, or in this point of view, yoga and many other such aspects can help a lot to improve the quality of life and prevent as well as cure all such NCDs, functional disorders. That has been very least addressed in this entire, although the theme is integrated health. That's it. Yeah.
Thank you. I think anybody wants to comment on that? I think.
Yes, I can.
Yeah.
And if I may, yeah. So we have recently started a pilot study on integrating yoga and Western medicine, if you will, in Mumbai. The initial phase hit into COVID, and we couldn't recruit participants. Now we have a small pilot of about a dozen participants that have enrolled in those programs. It tends to be very difficult to sort of combine the two. Partly because sometimes folks are sort of too excited about the non-Western, maybe non-scientific approach to health, that the goal of the intervention is to basically, for example, stop antihypertensives for a hypertensive patient. And in most places, if you do the study rigorously and you have to run it by an IRB council, an IRB would never correctly approve of that study. So the integration has to be done very carefully in the sense that people who need treatment should get it based on current guidelines. We can't deviate from current guidelines of treatment, but we can add on top of it additional resources. So our school, the Harvard Chan School of Public Health, has recently, as of 2 weeks ago, has started a new center named after Thich Nhat Hanh. It's a center for mindfulness and health, led by Professor Willett and others. And a lot of that research hopefully will happen in these. The current state of research on sort of alternative approaches to NCDs and many other conditions, unfortunately, the quality of the research is very, very low. You will see studies where the person basically believes that this works, and then they conduct a study in a way that shows that it works. And you can still publish that in some journal or the other, but that doesn't mean that it's rigorous evidence. So I think the test, the litmus test, should still be scientific rigor. But again, many scientists are open to experimenting with new approaches to controlling non-communicable diseases.
Thank you. We have another question from William Roberto Suarez. Is that the correct name? Please go ahead. Yes. Yeah, you are muted, I think. Go ahead with your comments or question. You are muted. Can you please unmute? Okay.
Okay.
Okay. I can hear you now.
Okay.
Okay. Hello, everybody. My name is William. I'm from Brazil. I'm a founding president of the NGO. I'm very happy to participate in this meeting, focus on the helping the humanity. My English is not very good. Barbara will talk about a bit about how our project approach this point.
Hello, everybody. My name is Barbara. I'm a volunteer at Fraternal House 8 Point of Good. We are an NGO institution founded in 2015 in Rio de Janeiro, Brazil. We have more than 2,500 registered families that are at social vulnerability. First, we would like to thank you for sharing so many reflections and knowledge today. And all of these families that we help, at least have one of these diseases that were discussed today. And what we realize is that a large percentage of these diseases are psychosomatic, mental, begin the mental plan, and then somatize, go to soma, which is the physical body. We must have in mind that everything is mental. The world we live in, the world is in our mind. So when we vibrate fear, insecurity, anxiety, and disharmony, in other words, lack of emotional control, when the true meaning of life is twisted, you lose your direction, your north. So knowing that the manifested world is dual, understanding the process is the key for mental health, reaching into the physical. Here at Point of Good, we attend 3 stages: first body, then mental and spiritual health, because only in an integrated way we can actually help these people and reduce the high percentage of non-communicable diseases. Once again, we want to thank you for the opportunity.
Thank you very much for your comment. In fact, the mental health is definitely an important issue because we have another vertical on mental health. That is why in the non-communicable diseases, we included only 4 major diseases: cardiovascular disease, diabetes, cancers, and COPD, chronic lung disease. Mental health, we have another vertical. I agree that definitely even within the NCDs, mental health, and as the previous comments mentioned about the stress, and that is also very, very important. Maybe we will end up with the last question. There's a question on the importance of peer groups. Maybe who wants to go about this? Peer support and peer group, how can we improve control with the help of peers? That was one of the comments.
Maybe I'll make a quick note. As I mentioned, that a study that was done in Kerala by our colleagues, I think in many places we have self-help groups that are, for example, in the context of Kerala, they are meeting for microfinance loans. And what we did in that trial was that our colleagues used those monthly meetings as a reminder for people to take care of themselves. And in this case, it was hypertension. Therefore, have you refilled your prescription? Have you visited your doctor, etc., etc.? And that increased the hypertension control in that population within 6 months by about 12 percentage points. So it went from about 25% to close to 30%. So that was very impressive, and we are looking to scale that up in the state and other places in India as well. Since that study was published, we have had a number of groups approaching us, because in other places we have, for example, related to Dr. Vijay Kumar's discussions, self-help groups for aging are also very common. People who meet regularly and discuss various issues, health or non-health, in Thailand, in Philippines, in many other countries. And there is a strong interest to embed strongly health and healthcare within those self-help groups. I think these are social structures that are there, can partly counterbalance the commercialization, in some places, the racism, for example, other social issues that people are dealing with because they are meeting with each other, and affects their mental health as well, as William Soares was mentioning in places like Brazil, in the favelas of Rio de Janeiro, elsewhere.
Thank you. So we come to the end of this panel discussion, And I think it has been a great experience listening to the reflections from people who have really worked with the communities. The reflections were, most of them were passionate, and I think it has struck a chord with all the participants here. And I would also like to thank the participants for a very interactive and all the questions. Thank them for all the questions that they asked, which made the discussion even more interactive and even more insightful. So we heard from Dr. Tim Evans, who told us about how the needs to be consistently triaged, and how in most of the low middle income countries, it is the informal sector which gives most employment, and therefore how the social insurance, health insurance might be lacking there. And regarding decentralization, we heard from Dr. Vijay Kumar on how one size does not fit all. And in order to succeed, we need locally tailored solutions with legal support and also citizen involvement, which would increase the accountability. So, and then about the risk factors, again, we heard about how the high income countries have managed to reduce their risk factors by 57%, and how now the hypertension and diabetes have also come to affect the people from the lower socioeconomic groups. And now there's a double burden of both poverty and risk factors, as well as non-communicable diseases. And how population level interventions could depend on what the intervention is in order to decide whether it would be effective or not, and how more studies are necessary in that area. We heard that from Dr. Gudas. And yes, Kerala would definitely like to take up that challenge with all the lawn scholars that are here. We would let us see if all the stars are aligned to see whether we would be successful with that. And with regard to health system, again, we heard from the champion himself, Dr. Sundaraman, how he has, I think it's good for all the public health activists and the people working in public health, how he developed the Mitanan in Chhattisgarh, which was later called Asha across the country. And how the network of primary health centers are the critical building blocks on which we can build continuity of care, referral, and how TB and HIV, how we can learn from what we have been able to do with TB and HIV. And yes, so what the people have done and how they have succeeded in pushing for policies and also serious action at the structural determinants of health, and how the commercial determinants are equally important and probably have got less emphasis than before. And from Dr. Asmita, a young and dynamic pulmonologist, we heard about how in COPD we need more taxes, as we have learned that the tobacco taxes have managed to bring down the use of tobacco, and how air pollution is necessary, early diagnosis with screening tests at the population level, and increase access to therapy. So I think with that, and with all our participants and all the people who have worked behind, Mr. Abhijit, Ms. Shivapriya, Mr. Rajesh, Ms. Krishnapriya, I thank all of them also. I take this opportunity to thank them for the successful conduct of this panel discussion on the NCD vertical on integrated and holistic health. Thank you very much, our eminent panelists who have taken time off their busy schedule to be with us and share their experiences. Thank you so much.
Thank you.
Thank you.